Palmetto GBA has previously announced that it would be recording the open meeting and that we consent to the recording. I've just started the recording of this open meeting in compliance with CMS. For the record, prior to doing so, I have announced that Palmetto GBA would be making an audio recording of this open meeting and consented on behalf of Palmetto GBA. The objective of the open meeting is to provide an open venue for stakeholders and interested parties to comment on a proposed LCD. The presentations are summaries of the comments and due to time constraints may not be comprehensive of all concerns. Presenters are asked to submit written comments and any supporting published peer-reviewed literature by July 14th, 2024 to a.policy@palmettogba.com or b.policy@palmettogba.com, which will be addressed in detail in the response to comments article. Presenters will each have 15 minutes, and at the conclusion of that time, the presenter will be muted and the next presenter promoted. Please be mindful of your allotted time frame to ensure you can share your closing remarks before your time concludes. Okay, the proposed LCDs can be found on the proposed LCD status report. If everybody is ready to start, we can start, please, with our first presenter. So this will be Dr. Jeffrey Rose from Atrium Health, and he will be speaking on artificial intelligence-enabled CT-based quantitative coronary topography, AI-QCT, coronary plaque analysis, which is corresponding to the DL39851 proposed LCD. Thank you. And I apologize for the delay.
No, thank you very much. And I appreciate the opportunity to present comments this morning on this particular topic. My name, as mentioned, Jeffrey Rose. Serve as the president of the Sanger Heart and Vascular Institute. I'm also a practicing cardiologist and have firsthand experience with this particular issue. If I may have the next slide, please. For the next few moments, what I would like to walk through is the concept of quantitative plaque analysis and its capabilities in providing more relevant clinical information about plaque or obstruction or stenosis in a coronary artery. I would like to build a case for supporting greater access to this technology in the care of our patients and have a specific comment on language as it pertains to the current LCD. For purposes of background, I think many are familiar with the concept that coronary artery disease is pervasive through our society. 1 in 5 people will die of coronary artery disease. We have made great strides over the last 60 years or so in significantly reducing mortality from coronary artery disease. In fact, reducing it by 50% through various technologies, including stents and statins. I think a greater awareness of prevention, but nonetheless, it still remains the #1 killer, if you will, of our population. While we have effective therapies to lower LDL, patients still are not getting to goal and not reflected on this particular slide, but there is still a significant incidence of coronary heart disease and events in patients who have what we would consider to be normal or therapeutic LDLs. And of course, the cost burden of treatment of this disorder is extensive, and you can see the figures here, upwards of $300 billion today and the projections by 2035. So this is a consequential issue. The treatments that we have been effective, but they're not enough to inflect where we need to be from a population health standpoint. What we have learned over the past decade plus is the fact that it's not just the degree of obstruction in an artery, but it's the total amount of plaque burden that really dictates outcome of how patients will do. It is natural to conclude that a patient with a 90% blockage is likely to, have symptoms and or troubles, and that has been the focus for a large degree of our strategies. But what we've also learned is that those who have burdens of less obstructive disease but greater burden have absolute risk over time, and the strongest prognostic value merely than just the presence or absence of a blockage of 60% or 70% or even 90%. And this has been shown in numerous studies, including prospective studies like the Scott Hart trial. As we get into the details, registry data that we've participated in shows once again that it is really the plaque volume, not the stenosis per se, that really dictates outcome over time. On this particular slide, in the middle, you'll see as we're looking at plaque-derived volume in terms of just total plaque burden, whether it has particular morphologic features, meaning whether or not the plaque may be calcified, whether it has low attenuation. These are incremental predictors, additive information that tells us which patient is at higher risk than another patient, totally tied to the cumulative amount of plaque burden. So again, the notion here is the complementary information of not just is there a blockage, again, of 30%, 50%, 70%, but what really is the plaque, total volume, and what are the characteristics of that plaque. Armed with that information, we can begin to take more appropriate care of our patients. So how do we do this? The benefit of this is that we're able to get this information non-invasively, so not having to take patients to the cath lab to do invasive, expensive testing. We're able to do this with current convention of CAT scanning and then applying AI-enabled algorithms to the images that are derived from these three-dimensional data sets and be able to calculate plaque characteristics. And you can see on this slide here the prognostic value of that information, being able to better risk stratify. By being able to risk stratify, we're able to more appropriately take care of patients. We have newer therapies today that are able to drive LDLs levels down to even lower levels than we have achieved before. And with this information, we can figure out what is the right approach for the right patient. So the question is, does this really work? The gold standard for measuring plaque volume has been an invasive study using intravascular ultrasound. When we use intravascular ultrasound in these studies, and numerous studies have been performed in different settings to be able to characterize plaque volume, plaque burden, plaque characteristics, and we compare that to what we're able to derive from CT images with AI-enabled algorithms, you can see the line of identity is matched in the corresponding graph. So we have a tool that is non-invasive, that is effective, that provides incremental, powerful information on a disease that is consequential to our patient population. So in terms of specifics, current language you can see as described, we would respectfully suggest that Palmetto consider adding the words stable or acute chest pain to the language. The rationale being that we have patients every day who are experiencing chest pain and are needing some type of a diagnostic evaluation. When coronary CT angiography is appropriate, we believe it is in the best interest of our patients to be able to provide them a full and complete description of their coronary anatomy and all the implications thereof, including prognostic value with respect to future risk of cardiac events. We believe that with that specific information, that better informs primary care physicians and cardiologists in making individual decisions with particular patients as to preventive goals, including aggressiveness of LDL therapy. So we believe that we can take better care of our patients with this information and believe that this should not be restricted solely to the acute chest pain scenario as was originally put forth. So I believe that this might be all that I have in terms of commentary. Ms. Abrams, not familiar with the presentation here. I'm happy to take questions if that is appropriate.
Thank you very much, Dr. Rose. I appreciate you giving this information. We will then move on to Dr. Campbell Rogers from HeartFlow, who will be speaking on artificial intelligence-enabled CT-based quantitative coronary topography, the AI-QCT coronary plaque analysis as well, referencing the same proposed LCD 39851. And once again, I will ask that if you are not presenting or speaking, you please remain muted and off camera so we can pay attention more fully. Thank you so much, everyone. Thank you, Dr. Rose and Dr. Rogers. We're ready to hear what you have to say. Thank you.
Thank you very much, and thank you for the opportunity to address this group. As instructed, we will be providing written commentary with all of the information and supporting documentation for the points I'm going to touch on over the next few minutes. What I'd like to do is over the next few minutes, and I'll do this not reiterating many of the spot-on comments Dr. Rose made, so I'm going to skip forward a little bit, provide an overview of the HeartFlow, and as a conflict of interest disclosure, I'm a full-time employee of HeartFlow, AI-enabled CPA, talk briefly about clinical evidence related to this, and finally, several suggested edits to the proposed LCD. So as a brief introduction to HeartFlow's AI coronary plaque analysis, this AI-enabled technology provides information, quantitative information about the volume of coronary plaque which exists in a patient's coronary arteries. You see that on the left, a patient-specific map of the coronaries and a table at the top, and the numbers in the table reflect the cubic millimeters of plaque, as well as the subtype of plaque, which those cubic millimeters are, calcified or non-calcified, or what's called low attenuation plaque. And then that's broken down by the vessel territory of the coronary arteries across the top, which reflect the columns. In addition, there are details provided per vessel. You see that in the middle panel of the three on this slide, images of the CT, images of the artery, as well as the plaque measurements for each of the coronary territories. And then finally, on the right in the report, in the analysis, there's information on a nomographic basis that allows a physician, knowing a patient's sex and age, to match that patient to their age and sex matched peers and say, among age and sex matched peers, this volume of plaque represents the X percentile of that population. The clinical data, much of which is included and referenced in the draft LCD and others which we'll be providing in our written comments, includes accuracy data. These published data, which Dr. Rose also referenced, are from a prospective multinational study comparing intravascular ultrasound, which is widely considered the gold standard for coronary plaque characterization and measurement, as compared to the AI-CPA AI-enabled product from HeartFlow. Additional clinical data, which is referenced in the draft LCD, is critically important and reflects on the utility of these technologies. And the DECODE publication you see here, which used the HeartFlow AI-CPA technology, ask the following question: how often does this tool specifically modify physician management of patients in isolation? How does it change management? And the finding was that in between 55 and 65% of patients, these tools modify management. So they are a diagnostic tool which is clearly having an impact on patient care when used. And then finally, as mentioned, the nomographic data, which is in our analysis as provided for each patient, is based on a publication in the literature, which is referenced on this slide, which leveraged data from approximately 12,000 patients across diverse health systems in North America, establishing these age and sex-matched nomograms. What I would like to do next is just walk through a series of suggested updates to the language in the proposed LCD. I would preface this by saying that the proposed LCD, certainly in its breadth and insights, offers a tremendous, I think it's a wise LCD. and is embracing of these technologies and for what they can mean for patients. But there are a few suggestions which we would like to put forward, and again, which we'll follow up with our written comments. The first of these is, and the rationale I will give on the next slide, but the first suggested revision is as follows. The current draft reads, quote, the patient presents with acute chest pain and no known CAD and is classified as, etc. We would suggest this be updated to the patient presents with stable or acute chest pain and known CAD and is classified as, etc. The edit being the addition of stable chest pain to this coverage determination. And this will walk through the rationale for this suggested coverage. Again, this will be included in our written comments. But in brief, the available clinical evidence and society guidelines support the use of both CTA and artificial intelligence coronary plaque analysis for both stable and acute populations, but not acute coronary syndrome populations. So they're very clear. The guidelines, as modified most recently in 2021 for chest pain evaluation from the American Heart Association and the American College of Cardiology, recognize both of these acute and stable chest pain populations as that CTA is an important tool for them. And the details are on this slide. Furthermore, at the bottom, the last big bullet on this slide, stable and acute populations, that verbiage would be in line with other parts of this draft LCD and other similar LCDs. So there would be consistency. For example, this draft LCD states that patients should be, quote, eligible for CTA, which should be performed in patients with stable coronary symptoms. So even in this draft LCD, that language exists. Second, the LCD for non-invasive fractional flow reserve, or FFRCT, also identifies that technology as medically necessary for both acute and stable chest pain patients. The second suggestion is as follows. The current draft coverage reads, the patient presents with acute chest pain and no known CAD and is classified as one or both intermediate risk, CAD-RADS 2 and CAD-RADS 3 category on CTA. We suggest this be updated to the patient presents with stable or acute chest pain, that edit we've already discussed, and no known CAD and is classified as one or both intermediate risk. And then the edits are in that second dark bullet, CAD-RADS 1, 2, 3, or 4 category on CTA. For those not familiar, the CAD-RADS categories categorize the level severity of stenosis, of narrowing of the coronary arteries as imaged on a CTA. And they range from 1 being somewhat narrowed, but not very much, to CAD-RADS 5, which is arteries that are totally blocked, severely narrowed. But in between are these 4 categories, 1 through 4, of progressively severe stenoses. And as we'll see on the next slide, there is good reason to think that for the added categories of CAD-RADS 1 and CAD-RADS 4, these technologies under the subject of the current draft LCD will be important tools. Similarly, we would suggest in a related edit that the verbiage not to be used in high-grade stenosis or CAD-RADS 4 or CAD-RADS 5 be updated to not to be used in high-grade stenosis. In other words, allowing CAD-RADS 4. So there's a secondary edit based on this. And the rationale for this is as follows, that in the DECODE study, which has been published and is referenced in the draft LCD, as mentioned earlier, we've looked and report the frequency with which management changes in each of these CAD-RADS categories. And with the AI quantitative plaque analysis tool. And the fact is that for CAD-RADS 1 patients, again, relatively modest stenosis, but still some coronary disease, which are excluded from the draft LCD, 40% of patients had their management changed based on this technology. At the other end of the spectrum, CAD-RADS 4 patients, again, excluded from the draft LCD, nearly 94% of those patients had their treatment changed based on the AI-CPA information, usually an intensification of medical therapy, which is what the stages on this slide reflect. So the rationale for this edit is that depriving these patients with this level of stenosis would be a mistake, and this technology should have utility in these populations. So that's the end of my comments. Thank you very much for the opportunity, and we will be submitting these as written comments as well.
Thank you very much, Dr. Rogers. I appreciate your presentation. It was extremely informative. Thank you very much. Our next presenter is Dr. Sarah Reinhardt from the Charleston Area Medical Center, and she will also be speaking on the artificial intelligence-enabled CT-based quantitative coronary topography, AI-QCT, coronary plaque analysis, AI-CPA, proposed LCD number DL39851. Welcome, Dr. Reinhardt.
Thank you so much for the opportunity to speak to you today. It is a project that I am very passionate about and have worked hard to gain insight on. So if you show the next slide, I just want to go through what the requests are. You know, we believe that this we were very appreciative of the draft coverage that you're currently including in the draft coverage policy, which includes symptomatic patients eligible for CTA and those at intermediate risk, which is most of our patients actually who go for cardiac CT, and especially those with CAD-RADS 2 and 3. But again, we are kind of wanting to expand that coverage for CAD-RADS 1 through 4, and we will talk about why we think that that request can be meaningful. So as we go through to the next slide, I want to talk to you about the DECODE trial. So if we looked at what our study objective was, you know, a lot of us weren't sure how we would utilize this tool, and this study really helped enable us to gain good insight in how we would use this tool to manage our patients. And first of all, you had 3 physicians who are very prevention oriented, but also read cardiac CT. So it's a very interesting patient or physician population because we're very proactive and engaged. But what you'll see is we wanted to look at the impact of our decision making based off this plaque analysis on top of the cardiac CT report. So when we looked at the cardiac CT only, we generally chose stage 2 therapy, which is an aspirin and high intensity statin, based upon the Friedman paper. And in and of itself, that is very insightful because we're already being aggressive at the forefront, sometimes more so than what we would consider some physicians may be in rural populations, so to speak. So when we looked at the plaque analysis on top of that, so we actually maintained therapy in about 1/3 of those patients, but 2 out of 3 patients, we actually refined their management plan. And the majority of that was to actually intensify therapy. Now, one of the things I want to highlight here, which we generally don't talk about, is stage 3 was a more additive therapy where it was more than just aspirin and statin therapy. We may have added Zetia or another therapy on top of that, but all of those patients, even though it was a small number, we actually still intensified therapy. The other thing that is important is that we reclassified about 50% of patients with a calcium score of 0. So as we go to the next slide, what we wanted to demonstrate was that regardless of the calcium score threshold, we were still intensifying therapy. Again, the people that we did not intensify therapy are those who had an LDL threshold that was quite low. But again, the majority of patients with a stenosis more than 50%, again, were intensified on their therapy. So again, as you look at this in a spectrum, even with a calcium score of 0, 47% were reclassified. And again, as the disease became higher, we reclassified even more, up to 96% of those patients. And again, the reclassification rate was even higher with 50% stenosis. But again, what I want to highlight is at both extremes, both high burden of disease, but also mild disease, we're still reclassifying in 50% of those patients. So as we go to the next slide, we have the CAD-RADS that we really chose the different therapies. So CAD-RADS 1, a lot of people might think that how are we going to reclassify them? But 40% were reclassified. And that may be because of the type of plaque or maybe even the burden of plaque. It could be the location of the plaque that was present. But even with minimal stenosis, 40% were reclassified. And again, what I want to highlight here, we're already seeing the huge benefit in the CAD-RADS 2 and 3 population, which is more of the non-obstructive disease, but higher burden of disease that you appropriately put into your draft coverage. But again, even though CAD-RADS 4, it's intuitive that we may want to be very aggressive in that medical therapy, we still intensified therapy in 94% of those patients. Because again, what we found is that we were not actually identifying necessarily the burden of disease, or when we took that second look, we realized that even with the therapies that we initially chose, they would not reach target. As we go to the next slide, these registries actually, that we're going to talk about, actually demonstrate the same findings. But when we're looking at the CAD-RADS document, all that we found about the more aggressive titration of medical therapy is supported by the CAD-RADS document, where they're saying anything that's more than 50%, they recommend more aggressive risk factor modification. But what I would say is that there's a different thought process in rural communities versus other, not just necessarily rural, but across the United States, about what aggressive or what the targets are actually being. So is that target less than 70? Is that target less than 55? I think the awareness just isn't present. And this actually is highlighted in these registries that we're going to talk about on the next slide. I guess it's the next slide after this. But this is actually going to the plaque 3 and 4 burden. So when we talk about CAD-RADS, they incorporated this P3 and P4. And what they're saying is that there is, again, is a recommendation for more aggressive therapy. But a lot of physicians are not necessarily using that CAD-RADS documentation, and the plaque grading is somewhat difficult, although it makes it applicable for anyone who has cardiac CT independent of having this plaque product. But again, one of the limitations is that what does aggressive risk factor modification and preventive therapy truly mean to the nurse practitioners, to the internists, to the cardiologists who are managing these patients downstream? And as we go forward, as I've mentioned before, ideally, we want a product that is independent of CAD-RADS, that really demonstrates that the total plaque volume is truly very important. It's the components of the plaque, it's the type of the plaque, it's not just about the luminal stenosis. And as we go forward, we're going to see the limitations that we are currently dealing with. So as we know, our risk factor modifications are very limited. You know, when we're using biomarkers, we've already proven throughout the decades that we're not achieving goal. One of the reasons we've shifted to cardiac CT is we've actually start preventive therapy before at the advent of the cardiac CT. And what this study shows is that we've actually sustained use of statin utility after the cardiac CT. But despite that, there's not much data that says, are we truly getting to goal? So as we move forward, we're going to talk about some of those limitations. So these are two different registries. The Gold Registry is in the United States, Santorini is more in Europe, but the message is very similar. And the Gold Registry in particular used our highest risk patients, those who have already had events or already been revascularized. So they may have had a stroke, they may have had a heart attack or a stent. And again, what you see is 2/3 of those patients actually have an LDL over 70. So they're not even meeting the old threshold for their disease burden. So when we look at our 2022 threshold of less than 55, we're really not meeting that target at all. And again, when we look at the Santorini, which is Europe, where they've been much more aggressive at trying to identify those LDL thresholds at a more aggressive stage, at an earlier stage a few years ago, what they found is that only 20% of those patients were meeting their LDL goals. And these are the highest risk patients. And part of the reason for that is there was inadequate risk classification and underutilization of the combination therapies, whether it's PCSK9s, it could be GLP-1s, Zetia, etc. So what we think is important as we're using this plaque product is to, number one, identify the thresholds appropriately, but number two, really highlight the use of combination therapy and what may be appropriate for those patients. So as we go to the next step, when we look at the quantitative insight over studies, we found that total plaque volume is very important in risk prediction. And this study in 2021 showed that when we have that plaque volume of over 100, it helps us reclassify patients from intermediate to high risk. And then when we have this plaque volume of over 238, it helps to identify even higher risk patients. And some of these patients only may have minimal or mild stenosis, or it could be a focal significant stenosis. But when you have that plaque volume of over 240, your hazard ratio is 7.3. So these are thresholds that are important, and we're actually able to quantify. And I think it's important to identify these aren't population-based. This is an individual patient-based metric that we can use to individualize care downstream. So this helps us to really uncover or identify unseen cardiovascular residual risk. So as we're going forward, we want to highlight how we've put all of these things together, because what we know is that we want the nurse practitioner, the internist, the cardiologist, regardless of their specialty, to be able to utilize this plaque information in a meaningful way, no matter where you are. So we've tried to identify stages of disease based off of those plaque volume thresholds that have demonstrated residual risk to the patient. And then what we say is that based on the prevention guidelines, if you have a percentile that's high, or you have risk enhancers, you may want to intensify that therapy. So we're trying to say these are the things that are considered high risk so that you can individualize that patient's care on an individual basis. And as we look forward, you can see this total plaque volume. We set the LDL threshold, but we're highlighting all of the therapies that have proven cardiovascular benefits, because a lot of these providers may not be aware of all the medications which are currently available, which have improved cardiovascular benefit. I think all of this really highlights how we try to incorporate everything on an individualized basis to, number one, identify the threshold, which we understand that a lot of people are missing, but also highlighting the combinations of therapy which can improve outcomes. So as I want to summarize everything, I want to highlight, number one, from clinical experience. I've been in a large center. I'm right now in a rural area. When we're looking at CADRAS 2 and 3, we're very appreciative of the coverage that you're drafting. But the CADRADS 1, what we see is that people aren't starting statin therapy, especially in these underserved communities. And if we highlight and start this disease process with minimal stenosis on the right therapies, hopefully we can decrease downstream events. But even on the advanced disease, we're missing those LDL thresholds. And we've shown that through the GOLD registry. Even our highest risk patients, 2/3 of the patients are not reaching goal. So we think that highlighting all of the therapies and the LDL thresholds for these products at both extremes can give all the patient populations a more individualized medical regimen that can decrease their cardiovascular outcomes and improve them downstream. So I thank you for your attention and the opportunity to speak today.
Thank you very much, Dr. Reinhardt, for that informative speech and presentation. We will now move on to Dr. Rick Fischella. Did I pronounce your name correctly?
Yes, you did. Thank you.
Excellent. You're welcome. And he will be speaking to us from AbbVie. Thank you. And again, please, everyone not speaking, not presenting, please mute yourselves and take yourself off video. Thank you very much.
Yes, I just really have two quick comments. We appreciate the Palmetto and their experience in writing their LCD for the MIGS procedures and the MIGS devices very much. And I just wanted to mention one quick item before we move off the slide. On page 3 at the very top of the MIGS, I think maybe possibly one of the computer generated, or as we're typing terms that came out inappropriately. On number 2, it says one supraconjunctival space stent, and it would be one subconjunctival space stent. That basically is consistent throughout the rest of the document. So I just wanted to mention that because it's not actually specifically for Zen, but other products also, if there were any. And the second statement is, again, as I had mentioned, we appreciate Palmetto's careful review of the LCD, and I would like to yield back my time to the other speakers.
Thank you, sir. I appreciate that. And I apologize for not introducing you with the micro-invasive glaucoma surgery MIGS proposed LCD, which can be referenced at DL37531 on the website. So thank you very much.
Thank you very much.
You're welcome, sir. Next, we have Dr. Zuzik, who will be giving a presentation on botulinum toxin injections. The proposed LCD can be found under DL39836. Thank you very much. And welcome, Dr. Zuzik.
So I want to kick off and thank everyone, including the medical directors, the CAC members, and the staff for the opportunity to present at today's meeting. So I'm presenting on behalf of AbbVie, specifically for botulinum toxin A, also known as Botox by its brand name. And I really do appreciate the opportunity to present on behalf of the physicians and the patients who have been touched by our product. So if we can move to the second slide, I just want to go through the fact that my disclosure is I'm a full-time employee and a shareholder at AbbVie Inc. I just want to touch on a few key large topics that have showed up in this LCD policy. We appreciate the immense effort that has gone on in the background in producing this draft policy on botulinum toxins. It is no easy feat. We understand that. There is a lot of moving parts and a lot of very interesting topics to cover in a botulinum toxin policy. I'm going to hit on some core topics on behalf of the totality of the product from a therapeutic perspective. The first piece we want to go over, slides 4 through 8, will cover indications of coverage. We have these organized in sort of a rank order of key topics. First is chronic migraine. Looking at the current draft policy, we have highlighted some comments in the draft policy in yellow. What I'd like to bring the members' attention to are the bullet points on the right-hand side of the slide that are in purple. The key piece here is looking at recent guideline updates in the headache space. The American Headache Society consensus guideline statement does place botulinum toxin and CGRPs as first-line therapies for chronic migraine. It is not seen from expert opinion that there's any need to place any other treatment modalities or compounds ahead of Monobot A. Additionally, many of the products listed in the proposed policy are not indicated by the FDA for migraine, and several have anticholinergic side effects, which should be minimized in patients over 65 years old. That's in reference to more recent evidence on the impact and potential onset of early dementia on long-term anticholinergic use in persons at age 65 years older. One of the other key pieces here in migraine is we're seeking clarification on statement number 8. As written, we understand the overall context. Our concern is whether or not it will be as easily interpreted at, let's say, the site of care. So we're asking that statement number 8 is revised to add some clarity in the verbiage, and we will add additional commentary to that in our written comments. So here in spasticity, very simply, I'm going to focus on, from here on in the presentation, the sort of light blue boxes at the bottom of these slides. We are respectfully requesting revisions to the language in the draft policy, explicitly on the moderate to severe chronic spasticity be removed from the policy. Current guidelines published by AAPM&R, that's the American Academy of Physical Medicine and Rehabilitation, do not state a need of severity level for treatment. Furthermore, it calls into question which measurement will be used to actually demonstrate moderate to severe spasticity. And in coordination with that as well, past AAN guidelines, the American Academy of Neurology guidelines, also did not state actual levels of severity of spasticity for which there is a need to then treat spasticity. For cervical dystonia, we are respectfully requesting rewording of the policy given the following key information: that the AAN guidelines do not state routine assessment utilizing objective measurements. A differential diagnosis of cervical dystonia encompasses mild to severe neck-head postures and/or associated pain. And on a botulinum toxin A label is approved broadly for treatment of cervical dystonia and associated neck pain. So we're calling to attention those items highlighted in yellow in the current draft policy with regards to cervical dystonia. We've provided additional information here that supports our request, and our written comments will provide further details. Here, we are specifically calling out the highlighted moderate to severe item in item 3. We are respectively requesting that moderate to severe neurogenic protrusive activity is removed from the current policy. As noted, the additional information here in supporting this request has to do with current guidelines. Furthermore, that this is also not included as language within Onabot A's label for NDO. Staying within the urologic space, we're now looking at overactive bladder, also known as OAB. We are providing additional information here on both the approval of Onabot A for OAB. Additional information is provided in the phase 3 studies, as well as calling to reference the most recent AUA SUFU Joint Medical Society guidelines on overactive bladder and NDO. So we are respectively requesting that moderate to severe and objective assessments are removed from the draft LCD policy, as well as eliminating the need for conservative and pharmacologic management before Onabot A therapy, as the recent guidelines have actually removed first, second, third line naming schemes and have placed Onabot A in a group of minimally invasive therapies. And the guidelines additionally call out that you may initiate Onabot A without having gone through an additional oral therapies or failures, etc. So we will call out that additional information in greater detail in our written comments. For slide 9, we are requesting that the LCD draft policy update its definition for spasticity. The definition of spasticity actually has changed considerably, seemingly every 5 to 10 years. And most recently, in the publications of the most recent guidelines on spasticity management from AAPM&R, we're requesting that the policy update and align to the definition of spasticity that's included in that 2024 AAPM&R consensus guidance on spasticity assessment and management. We're now back to cervical dystonia, and as highlighted in the factors associated with cervical dystonia and muscle suction for the indication, we are respectively requesting that the policy revise its statement to expand to any of the approved muscles. Though we understand the potential scientific basis for calling out these few specific muscles, we do think it's best to consider any and all of the approved muscles, as not all patients may have postures and or pain related to those postures associated with these muscles or muscle areas. Moving on to dosing limitations and muscle selections and spasticity, we are requesting that the policy consider revisions to the language with dosing around dosing and muscle selection and spasticity. We requested that initial dosing of Onabot A for adult lower limb spasticity is 75 to 400 units, and that the subsequent dosing of Onabot A is dosed up to 400 units divided among the selected approved muscles. What's noteworthy here is that the current draft policy also mentions a upper limit or upper cumulative dose of Onabot A as 360 units, which is outdated by almost a decade. That 360 unit upper threshold was removed in 2016 by the FDA with the approval of lower limb adult spasticity and additional safety evidence in upper limb spasticity that since 2016, the Onabot A label has had an upper limit of 400 units noted. The current draft policy, again, staying within spasticity, does not mention pediatric spasticity. We just want to call to attention, as noted in the spasticity section, that some of the other botulinum toxins that do have approval for pediatric spasticity do have their pediatric dosing mentioned. We are respectively requesting that the LCD draft policy do include our pediatric dosing for Onabot A. It's as simple as that. Looking at the dosing limitations and muscle selection across neurogenic bladder, we're respectively requesting that the LCD policy include dosing up to 300 units as provided in information and data in the Onabot A label. So for some patients with neurogenic bladder throughout the phase 3 trial, if efficacy was not achieved with 200 units, there was the capacity to move up to 300 units. This is supported with data from our registrational trials. Staying with the urologic indications for overactive bladder, the highlighted items we're asking for revisions. And again, we will provide deeper details with our written commentary. We're requesting that the policy allows for doses up to 200 units in overactive bladder in patients with overactive bladder, which is supported by the AUA guidelines and clinical trial data. So again, in overactive bladder patients in our registrational trials and an additional study called Rosetta, which was performed by the NIH, funded by the NIH, it has demonstrated that safety and efficacy were similar. For those patients who were not receiving benefit with 100 units, they were able to dose escalate up to 200 units, and they were able to achieve the efficacy as similar as demonstrated on label from our pivotal trials. So looking at blepharospasm, one of the key things we would like to call out here, again, respectfully requesting that the wording in the policy reflect the Botulinum toxin A label. So that would be looking at the items that are highlighted here for blepharospasm. We would like the LCD policy to reflect the Onabot A label, which is stating that is the dose per site, not per eye. So as you'll notice, the first item highlighted in yellow says 5 units per eye. The Onabot A label explicitly states 5 units per site around the eye. And additionally, the cumulative dose for Onabot A in any given 30-day period of injection for blepharospasm should not exceed 200 units. We noted that the draft LCD policy was missing this key piece of information, which is critical in supporting those patients suffering from blepharospasm. The current policy has a blanket statement, which is calling out that imaging guidance, so ultrasound, is not considered reasonable and necessary for injection of botulinum toxin based on the evidence that exists published in the literature. We do respectively disagree and request that the LCD policy include that imaging guidance is considered reasonable for initial and subsequent injection of botulinum toxins for conditions, especially cervical dystonia and spasticity. We think the level of evidence is high and supports the utility of administering botulinum toxins under ultrasound. And final comment for the day is we noted that a significant number of ICD-10 codes were missing in the current draft policy compared to the previous policy. We will be going into deeper detail with our written comments. We are respectively requesting that these codes be reinstated, re-included in the policy, as they may cause significant miss and care. I want to thank everyone for their time. If there are any questions, happy to answer them now, or we will provide answers in our written commentary.
Thank you very much, Dr. Zizik, for that informative presentation. Appreciate it greatly. We will move on to our next presenter, Dr. Leon Herndon from Duke University, who will be speaking on the MIGS program, proposed LCD that can be referenced again at DL37531 on the website. Thank you very much. We are running a little bit early. If it would be amenable, we will move on to Dr. Jennifer A. Sivak-Calcott from Mon Health, Vidalia Health. Are you available, ma'am? Dr. Sivak-Calcott will be discussing the botulinum toxin injections, DL39836. We appreciate you all being patient with us and with these two presenters. We're going to give them a little bit more time. Thank you very much. And it does look like Dr. Sivak-Calcott is here. Dr. Sivak-Calcott, I am Dr. Jennifer Abrams. I am one of the consultant medical directors here at Palmetto GBA. And Dr. Sivak-Calcott is going to be discussing botulinum toxin injections, and you can reference DL39836. She is presenting through Mon Health, Vidalia Health. I apologize if I said that wrong. Thank you and welcome.
Well, on behalf of AAO, ASOPers, and NANOS, I very much appreciate you revisiting these coverage guidelines. I have no disclosures. Next slide. So blepharospasm is a disease which causes the eyes to forcefully close so much that the patient is unable to open them. It's a chronic condition that is treatable, but like diabetes, it requires lifelong management with medication. The exact etiology of why muscles around the eye involuntarily contract is not known. This disease progresses over time and it interferes with normal activities such as reading or driving. Before the late 1980s, we really had no good treatment for blepharospasm, but when botulinum toxin became available, it really revolutionized the treatment for this disease. It is the first-line, most effective treatment for benign essential blepharospasm, but and it has been the standard of care for the last 40 years. There are clinical guidelines for injection pattern and dosage which best accomplish relief for these patients. It would be unethical to subject medical care patients to non-standard care by depriving them of medical coverage. Next slide. Now, just to make a note, to date, Palmetto has really done an excellent job of providing coverage for my patients so they can live normally. The language in the new LCD is derived from the FDA's 1989 label for Botox. But as you look at this, rather than listing units per injection site as it does on the label, it lists 5 units per eye. Well, 5 units would not work. The patient would essentially be untreated. Next slide. And there are more reasons for concern with this application of the Botox FDA label. It's an unconventional approach to medical coverage policy. The FDA package label is not intended to be an absolute treatment guideline. The LCD only references the FDA label for Botox, but Xeomin, which is another form of botulinum toxin, is also FDA approved for benign essential blepharospasm. Now, these labels are meant to be an initial recommendation, not a maximum limit. And really, since 1989, clinical practice has evolved significantly. Now, while we appreciate the LCD acknowledgement that off-label use may be approved with robust clinical evidence, requiring the submission of 2+ studies is incredibly burdensome to Medicare patients, especially given the propensity of off-label use. And quite frankly, the patients, they just won't get care. Medicare patients and providers really deserve a straightforward path to coverage. Next slide. Overly restrictive limitations on dose and site will result in delays or denial of medically necessary care. So, I have patients that sometimes can't come to their appointment. I'm located in West Virginia due to weather, whether it's flooding or winter or what have you. And, by the time they're able to come, their Botox is worn off. They can't drive themselves. And so now they have to find someone to bring them, and they're further delayed. And this is going to lead to unnecessary out-of-pocket expenses, which disincentivizes patient adherence to medically necessary treatment. So the standard of care injection sites for blepharospasm include all the protractors of the eyelid. This involves at least 6 injection sites between 2.5 to 5 units at each site, and it's been the standard of care since the 1980s, as you can see in this diagram from a 1987 paper. But most importantly, the injection pattern and the dose is really based on the patient's quality of life in response to treatment. And the disease evolves over time, so the ability to determine which sites at the time you're seeing that patient is really key to getting the best outcome. Severity scales are not used in practice, and they would be tremendously burdensome and really not practical. Most of my patients require between 6 and 8 injection sites per eye, and they never need more than 1 vial of Botox. Effective policy would not arbitrarily limit the number of injection sites or the dose. Next slide. So as proposed, the LCD language would disrupt best clinical practice, interrupt patient treatment, cause poor outcomes, and severely limit these patients in their ability to do normal activities like use a computer, work, drive, and even increase the risk of falls. This is a chronic disease, so just like hypertension or diabetes where you may need to adjust medication dosage, it's the same for blepharospasm. And so policy really needs to be written to allow treatment to be adapted over time and to allow the use of other forms of botulinum toxin like Xeomin, for example, which is FDA approved for blepharospasm. Next slide. The new policy should align with the contemporary clinical guidelines. Here's an example from a 2024 article where they injected botulinum toxin every 3 to 4 months, a dose of 2.5 to 5 units per site, 4 to 8 sites per eye. And next slide. And just let me stress again, Palmetto's coverage has been very good for my patients over the last 20 plus years. But now the language in the new proposed LCD really won't allow for this good care. Now, in the same LCD, there is language that would allow for current best practice, and it's shown here, and it's under the section of oral facial dystonia. Well, blepharospasm is a facial dystonia. So in summary, the AAO, ASOPers, and NANOS encourage policy revisions to support physician discretion and patients' access to medically necessary care. Our organizations will follow up with detailed recommendations in the submission of written comments with supporting literature. Thank you very much for your time. Do you have any questions that I can answer for you?
Not at this time, ma'am. All questions will be addressed in the comment period. Thank you.
Okay.
Thank you very much. Dr. Sivak-Calcott, I do appreciate your participation and your excellent presentation. I am hoping that Dr. Herndon has been able to get online from Duke University to give his presentation on micro-invasive glaucoma surgery, the MIGS policy referencing DL37531. And again, we ask if you are not presenting, please stay off camera and mute yourself. Thank you very much for your patience. I've just received word that Dr. Herndon is not here yet, but he should be here within the next several minutes. Again, I apologize for the delay. We are running a bit ahead of schedule, and hopefully he will be here shortly. Thank you very much. And once again, we at Palmetto GBA appreciate your patience and your participation. Dr. Herndon,
Yes,
welcome.
thank you.
Welcome, sir. I apologize you required the second link. I'm glad to
problem.
have you here now. Can you see your slides, sir?
I can.
Okay, I will introduce you once again so you can hear it. This will be our last presentation will be from Dr. Leon Herndon from Duke University, and he will be speaking on the micro-invasive glaucoma surgery MIGS proposed LCD, which can be referenced by looking up DL37531. And Dr. Herndon, I'm Dr. Jennifer Abrams, one of the CMDs from Palmetto GBA. Thank you very much for being here today.
These are my disclosures. So thank you so much for allowing us some time this morning. First and foremost, we'd like to express our appreciation for working with the Contract Medical Director Work Group over the last year on this policy. This iterative public comment process has resulted in a proposed LCD, which overall reflects current practice patterns and allows for the physician and the patient to come to treatment decisions that work best for that unique patient. We also appreciate the addition of the section on healthcare disparities, which highlights the disproportionate disease burden of glaucoma on minorities, particularly African Americans and Latinos. We wholeheartedly agree that more research is needed to better understand differences in treatment, and that future research must include more diverse study populations. Our societies appreciate the opportunity to present today and to offer a few additional recommendations to further improve the proposed policy so that all glaucoma patients may be afforded access to the treatment that best suits their situation. So clarifications to indications of coverage. We agree with the proposed coverage of stents described in the indications of coverage. It's probably just a typo, but in number 2, we know that the correct terminology is subconjunctival, not supra. These devices drain aqueous into the space under the conjunctiva or the subconjunctival space to reduce the pressure in the eye. While phacoemulsification with a single MIGS procedure is indicated as covered in the limitations of coverage section, for clarity, we think it makes more sense to include it in the indications of coverage section. We recommend using similar coverage language already found within the LCD and creating a separate number 3 bullet as shown on the screen. Recommended changes to limitations of coverage. As a result, corresponding changes to the limitations of coverage should be made. For limitation number 2, we ask for just a slight clarification. We recommend changing patient to eye because glaucoma can be bilateral. For consistency and clarity, we recommend that limitation number 3 read, phacoemulsification and intraocular lens placement performed with a combination of MIGS procedures at the same time of service in the same eye is not covered. The intent remains the same, non-coverage for multiple MIGS procedures with cataract surgery, but this language will be more clear to physicians and coders. Although we understand why limitation number 3 is in the policy at this time, our organizations call your attention to the growing body of evidence that shows improved outcomes in patient experience when MIGS procedures are combined. A 2023 study by Dickinson et al. Found significantly greater reduction in glaucoma medications while maintaining similar rates of IOP reduction and low complications when cataract surgery was combined with microstent and canaloplasty compared to cataract surgery and microstent alone. Although there is currently not enough evidence for combining MIGS as a standalone procedure, we expect strong evidence to grow. Not only can the reduction in glaucoma medications improve the patient experience, it may also reduce costs to the healthcare system. We feel that it is important for a surgeon to have this tool in his or her toolbox for patients who may benefit from reduced or eliminated medication burden. We appreciate the list of definitions included in the LCD because it helps everyone speak the same language. With that goal in mind, we encourage you to update the definition of refractory glaucoma to align with the definition agreed upon and established by our societies in our 2021 consensus statement. While similar to the proposed definition, we feel that the additional specificity in the consensus statement definition reflects how a glaucoma specialist thinks about the disease. This particular definition focuses on medical treatment, and we agree with your proposed definition. The failure of surgical treatment should be included. In summary, patients with glaucoma, which disproportionately affects Black and Hispanic patients, need access to a range of surgical procedures. Our organizations appreciate that this is generally recognized throughout the proposed LCD. For many patients, treatment with medications is inadequate, and their glaucoma is not at a stage requiring more invasive procedures such as trabeculectomy and tube shunts. For these patients, MIGS help to preserve quality of life and reduce total cost to the healthcare system. We support further studies to investigate the indications of combining phacoemulsification with intraocular lens implantation with more than one MIGS procedure. We ask that carriers expand coverage when more outcome data are available. And finally, we look forward to continuing this dialogue, and we'll be submitting formal comments with PDF copies of studies on multiple MIGS procedures combined with phaco-IOL. Thank you.
Thank you, Dr. Herndon, and thank you to all of our presenters today. Thank you very much for your thorough and excellent presentations. On behalf of Palmetto GBA, we have finished all of our presenters. I would like to thank each and every one of you on your presentations and remind everyone that all written comments and supportive literature should be submitted by the date of July 14th, 2024. I wish you all an excellent morning and a good afternoon, and we will now end our recording. Thank you again on behalf of Palmetto GBA.